Safe Texas. Our mission is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards for community health by implementing innovative techniques and systems for the delivery of emergency care for the entire population. Next on our agenda is discussion about the position paper that came from this committee on physician supervision of EMS students while on clinical rotations. That paper was taken to the council at the last meeting. At that time, there was some concern from the education and EMS committees that they had not seen it. And therefore, today it went to the education committee already, and we'll go to EMS this afternoon. Dr. Beeson attended the education committee, and I'd like to ask him for a report.
Well, I missed the first portion of the conversation there, but the gist of it was some educational programs have concerns about the strain that requiring a medical director to sign off on agreements may create. I tried to reaffirm the fact that Texas is delegated practice, and as medical directors, we delegate to the providers and to the roster of that provider, and that a provider cannot, redelegate the delegation of practice. And so there's really it seems very black and white, but it sounds gray to all those that are speaking of this. I still reaffirm the position that the medical director should be involved, and if we're going to delegate our practice to a provider, then there must also be an agreement that we will be delegating our practice to the students of said programs that happen to be working on our providers, ambulances, and working with our providers.
Okay. Jane, do you have access to the projector, or can somebody project the? We'll put up the position statement. I can read it real quickly. I found it, and then I'll ask the committee if we've changed our minds. Okay. There were 3 bullet points, and the first bullet point is, while functioning within an EMS system, all practicing providers and students fall under the authority of the EMS system medical director. Everybody good with that? Still? Okay, number 2, the affiliation agreement between an EMS system and a training program should reflect the authority of an EMS medical director for all care provided. Reaffirmation? Okay. And then number 3, which I think is the bigger concern, DSH should add a requirement to program approval regulations that requires the EMS system medical director's approval on any affiliation agreements between EMS systems and training programs. And that's the concern. Are we staying with our previous decision that we think the medical director should sign?
I haven't been convinced otherwise.
The only semantics I will say is we say EMS systems, and I think they're actually recognized as providers. Is that correct, Maxie? That there may be a wording thing we would like to correct.
It was brought up in the the EMS committee that sometimes the medical directors change, and that might be an issue.
Can you get the microphone? Microphone.
If there are, particularly I guess in the Houston area, there may be changes in the medical directors kind of regularly, and that may create a problem for a lot of schools.
Okay. All right. I'll ask if there's any discussion from the audience or any complaints, concerns. Okay. Are you coming to the microphone?
Yeah.
Okay. So the only issue from the committee is the word provider versus systems?
Well, they talked a lot about just talking. More communication should go on before the students ever get on the truck to decide exactly how you want it to work.
All right. All right. Yes, sir.
My name is Jerry Densmore. I'm with PERCOM. I was also at the Education Committee meeting, and my take on it is you're asking for this to be put in the education rule. To me, because of the issues of medical directors leaving, new medical director coming in, nullifying a contract, and we might not even know as a program is nullified because that medical director is no longer there, to me it would make more sense to put this in a provider rule and force the providers to inform the medical directors of who they have clinical affiliation agreements with and when they sign a new clinical affiliation agreement. instead of putting the onus on the programs to try to chase down each individual EMS service that we have an agreement with and ensure that their medical director is the same one they had last month, the month before last, the month before last. Thank you.
Jerry, before you walk away, I have a question. You as a educational program director or coordinator, whatever your title is, do you not already have that relationship with, I mean, you're sending your students to locations that is it the assumption that they're precepting or educating your students like you would want them to be? Or do you already have that relationship with those providers and their medical directors to ensure that what your educational facilities objectives are that are being met at that site?
We do more of our liaising and stuff of that nature with the actual preceptor that's riding with the student. We provide a preceptor training manual, the goals that we want that student to be going through while he's on these rotations, whether it's the final field internship or the pre-rotations that they do before they get to that capstone piece. We don't generally deal with the medical directors of each individual service that we have an agreement with, because we want to end up dealing with the in-service provider, the guy that's going to be sitting there in the back of the truck with the student as he's going through and achieving these goals that we're looking for the student to have.
I agree with you on the educational piece, but how do you ensure that your sites that are doing your clinical preceptorship is meeting the clinical standards that you want your students to get?
Basically, before we sign with a new clinical site, we review their protocols, their operating system. Is that set of protocols, the way that they handle their business, going to be enhancing our students' experience, or is it below our level of expectation? If it's below our level of expectation, we don't sign with that service.
So when I, as a medical director, change my protocols, how are you made aware of that?
I would expect that the ops director would let our clinical coordinator know that there has been a change in protocols. Usually services don't downgrade their protocols to something less than what they already have. They might add new modalities of treatment, new things that come on the market, but rarely have I ever heard of anybody going, oh, we're going to quit doing all that and we're going back down to this little bare basement level.
But what if they change medical directors?
That's a problem. That's where I'm going with this. If they change medical directors and they change their entire program of how they're doing things, I would expect the ops director to let me know. If that doesn't happen, then in the feedback I get from the students, every shift we have shift evaluations, and if they're sending us feedback saying, hey, you know, we're not getting anything here, they're not doing anything, whatever, then that's a clue for us to start looking at that particular service. And we have services that we've had agreements with that we no longer utilize because of student feedback.
So, okay, because in my perception, this would actually help you ensure that your clinical standards are being met. And I'm just trying to flip it on, obviously, but I think, I mean, obviously being an educator, I believe in this, in what we're trying to do for the students. And so to me, this is really a protection for the students, because right now we're assuming that they have protection because of all these agreements that we've done forever. Just because we've done it forever doesn't mean we're doing it right. And so this is our opportunity to fix this, not for those in the past, but for those in the future.
I understand, and I want you to understand, I'm not speaking out against the educational benefit of this whole idea. I'm speaking out as a businessman against the logistics of implementation and long-term logistics of upkeeping this kind of system, where if medical directors change, and the also liability, because if that medical director there leaves and I didn't find out, and I sent students to him, and my contract's no longer valid because he left and he's the one that signed it, then I have liability with dishes because I just sent these students to a site that I actually do not have a valid agreement with anymore.
How many agreements do you think the average school has? Do you
I
have any
can tell
idea?
you the average, I'd say at least 10. I know we have upwards of 30.
Okay.
Wow.
Okay?
Okay.
Lots.
Thank you, Jerry.
It's hard to maintain the quality for that. All right. So it sounds, somebody correct me if I'm wrong, but it sounds to me like nobody's opposed to this. It's the devil's in the details of the rule. Is that accurate?
Well, where the signature goes, right? Whether it be,
That comes down to
Right.
signature thing.
Yeah, but that'll be the rulemaking for DSHS. Is
So
that correct?
it sounds like the question is about this concern about a administrative burden of trying to track down different medical directors, but aren't there different legal mechanisms to assist with that? If you have a contract with an entity and that leadership of that entity changes, it doesn't mean that contract goes away, it means there's a continuation process that's put in place. And so I'm not attorney savvy enough to know what those mechanisms are, but I don't think that just because there is the medical director changeover, that this burden is quite what's being presented. I think there are legal mechanisms that can probably assist in that process in the words and terms of the agreement that would allow you to have that flexibility. So.
Okay. Let's hear from the chair of the Education Committee.
My name's Jody Harbert, and I'm here to help. I think that
Not with those shoes.
I'm actually not here as education chair. My name's Jody Harbert, and I'm a clinical coordinator at Tarrant County College. And I can tell you, and actually want to speak from that venue only, that I applaud what you're doing. I think that Dr. Beeson said something earlier, and that is that we keep doing what we've always done just because we've always done it. And certainly I hear a lot of people telling me a lot of things about this, and I can tell you as clinical coordinator with more than 13 pre-hospital departments that I'm responsible for, we have to communicate. And I think the days of just making a phone call are not there. If for some reason we have medical directors that we don't have the mechanism to have contact with, I think that's a problem. I think we need to go find another medical director. I think with fax, if you want to be that old, if you want to scan it, if you want to email it, if you want to FaceTime it, if you want to Skype it, if you want to whatever, having communication with that many people to me is not that big of an issue. I think with technology, it's going to make it much, much easier. I think the burden of proof, though, does lie upon us to make sure that we know what our students are responsible for and that the service medical director and the school medical director have some contact. And I think the only way, we can't assure it, but if you sign your name to the dotted line, that tells me that Dr. Ellaby and my medical director have talked. They have agreed. We know what's going on. We can do these verbally, but I don't think we are standing on solid footing by doing these verbally. I think by taking the time, whether it's email, and that could be quick. I'm aware of your protocols. We're going to work together. Thanks. Reply. Okay. Done. You take that. You stick it in your file. Now we have something done. I don't know how long it would take dishes to get the wording down to actually put that into a document. But I think in the meantime we have some ways. And if a program has multiple medical directors, I think having that yearly chat and putting in that contract that if you change medical directors, you have 30 days, 40 days to contact us that you've changed, so that then we can have another affiliation agreement or a subsequent or an MOA or an MOU done. I think most of us are looking for more medical director involvement to make our programs better, so I applaud what you're doing. Thank you.
Thanks. Okay. All right, so we're good with it still? Is that the, okay, excellent. I'm going to skip down to number 11. There is a request that we have a member of this committee be a representative on the Trauma Systems Committee Registry Work Group. Is there somebody in here that can give me the Reader's Digest version of exactly what they want? I can go off my memory from what they told me last time. They want a member of this committee, it's not supposed to be a lot of work, you know, we always hear that. But want somebody to represent us and to be the liaison between that work group and the medical directors, just to represent us there, not to set up the registry, not to do any of the heavy lifting.
That's fine. I'll do it.
Did he say he'd do it like that quickly?
Just to
Wow.
clarify, can you be clear about what your name is?
Jeff?
Label
yes.
says.
I'd like to take this
right.
opportunity to mention that I'm resigning as medical director for MedStar.
No, that's fine. I actually
Excellent.
I just got placed on the NMSIS board from the National Association of EMS Physicians, so it would be nice for me to help Texas overcome its issues with NMSIS, so this would be a great opportunity. Thank you.
Wow.
I'm honored to accept the nomination.
Thank you. Thank you, Dr. Beeson. Jarvis.
Have to send him out of the room.
Wow, that was like the easiest thing we probably do all day. Okay, so I'm going to jump back up, and is Dr. Nemeth here to talk about the TCEP EMS medical director? No, he is not. Several of us were at that meeting. To remind everybody, this year was the first year that TCEP had our EMS medical director track at the Texas EMS meeting. The number of participants was down, but overall, I think everyone saw it as a success, and we're going to continue it for the next year. Anybody else?
I think I agree. I think it was good. It was a new venue, and I think the numbers will grow. I know it was nice to have just as many, if not more, providers in the room as there were medical directors, and it was a great opportunity. I know that the conference is changing this year and how they're tracking thing, and I'm hoping that the medical director's track can still fit into however they're changing. So.
All right, and then next we'll go to number 4. This is a carryover from the last meeting where we discussed the position paper on EMS transport to freestanding emergency medical care facilities. Because of the discussion at the last meeting and the changes we made, I thought it was appropriate to bring it back to this committee before going to GTAC for consideration. I'd like to open the discussion to make things even more exciting and interesting, and in full transparency, at 7 o'clock this morning, a freestanding emergency care facility in Cedar Park opened up, which I became the medical director of, which I didn't even know about till like 3 weeks ago. But we haven't seen a patient yet, so I'm not sure how this affects us. Anyway, but a number of us up here at the table and in the audience are now working at some of these freestanding facilities, and they're popping up everywhere. I think it's very important that we discuss what to do with them. If it's okay, I'm going to turn it to Dr. Bradley, who worked on this initially.
Sure, thank you. And so I'll just recap. This is a fairly brief position statement, 2.5 pages. And most of it is just reviewing either the current Texas laws on freestanding emergency centers or talking a little bit about the ethical issues involved. The Texas Health and Safety Code and the Texas Administrative Code do require that every freestanding emergency department have a plan for patient transfer when a patient arrives that needs care beyond their ability. There are a number of issues, but basically focusing, I think what's important is for us to focus on what's important for the patients.
Can you scroll down to recommendations?
And from a patient perspective, the concerns obviously are time to treatment for critical conditions. And we did a very brief review of the literature, and there is no literature to tell us whether time to critical interventions is shortened or extended by the use of freestanding emergency centers. So there's no evidence to point us in either direction. So the recommendation, which is the last few lines of this statement, basically say it's the EMS Medical Director Committee of GTAC. Should I read it, or is that there?
That's different. That's actually different than the one I have.
Okay. The EMS Medical Director Committee of GTAC's position is that current Texas statute and rules regarding EMS transportation to freestanding emergency facilities are adequate. The EMS Medical Director for each EMS provider should, in consultation with local freestanding emergency care facilities and in consideration of any regional guidelines, determine the capacity and capability to receive EMS patients. It goes on a couple more lines, but basically it says that the decision of whether or not an EMS system should transport to a freestanding emergency center should be made by the EMS Medical Director of each provider. And that we believe that current state laws and rules are adequate.
Okay, so as we're working on pulling up the current one on the display, I don't know how many people have it in front of them and have looked at it. Is there discussion from the committee regarding the updated version?
My only question is the word freestanding. Are we solely dealing with freestanding facilities, or is this also to encompass the standalone facilities?
And I think we struggled with that. We're talking about all the variety of urgent care centers, emergency departments. What we just opened was an emergency hospital that has 8 emergency department beds, 8 inpatient beds. I don't know how do we describe these facilities?
So that's the difficulty, right? The nomenclature associated with this, and it's not well-defined in any of our documents, and so we have to be very careful with that. And standalones, they're satellite facilities. The standalone facilities, which are essentially licensed as special hospitals versus the freestandings and the different rules and processes that go with those. So I think as EMS medical directors, our engagement is with all of those, that entire spectrum, not just isolating it to the freestanding emergency centers that would be then interpreted under the rule.
I appreciate you saying that, Craig. Just to clarify, this document uses the term freestanding emergency center, and it footnotes the Texas Health and Safety Code that refers to freestanding emergency centers. So if you included those footnotes as part of the document, then it's specific for 24-hour freestanding emergency centers and doesn't address the rest.
And to me, the key there is, I went through this once in Colorado years ago. If you put the word emergency on the side of your building, you're opening yourself up for a whole nother standard of care and the things that go along with that.
We want something to help the state and help EMS medical directors in their decision. What nomenclature should we use? So we don't get into that's only a position statement about freestanding ERs. That doesn't apply to our facility.
Right,
But there's a ton of facilities.
I would say that the definition of a freestanding emergency care center is defined in Texas state law.
Yes, and by citing that and using that word, this statement only deals with those types of facilities, and not what I think we're all struggling with is the non-traditional emergency department that we are transporting or non-transporting to. And I don't know the answer.
So we're going to leave it up to the medical director to determine if their CAT scan's working, and if they have TPA and stroke patients and all that.
Correct.
And what if
Just
that
like we do
varies
with any
on
other
for
hospital.
certain
Yeah,
days?
just like we do with any other.
Just like we do with any other hospital. Obviously, if we have a smaller facility, and they only have one CAT scan, it can go, and will go down. And we have a responsibility to understand what those contingency plans are.
So they should be in our dispatch system? They should be reporting to our dispatchers if their CAT scan's down, so that we don't waste time going to the wrong place?
I think what the position statement says is that it is up to us to figure out where we're going to transport patients. So, for example, if I have an emergency center in my district that does not, I'm not convinced, has the capability to care for my patients, and I'm not transporting there, then quite honestly, it doesn't matter to me whether their CT scan is up
Sure.
or not.
Quite a bit of experience with non-traditional destinations. I support the document, but I ask you to be a little cautious on the wording, because alternate destinations really are going to key off of this a little bit. You know, we had set up a very successful program for diverting stable psychiatric patients away from the emergency department. Again, we're reverting them to a community resource, and it is the medical director's responsibility to verify all of those things and set up the communication, et cetera. So I support the document. It's been successful, I know, at least in Montgomery County. But I'd hate to get stuck on, hospital-supported, freestanding, satellite system. I understand that freestanding is defined in the statute, which is good, but I would actually want to broaden that definition out to where if you wanted to transport to a non-hospital, non-traditional hospital facility that may not even be a freestanding emergency department, it's the medical director's responsibility to make sure that all the components are there to do that safely, appropriately. So I'm just asking for broaden that thought process out and think a little bit forward, because community resources, particularly for might be appropriate for our guys to pick them up the field and take them there, completely bypassing the emergency department.
Is there a specific part of, I agree, we certainly don't want to limit our options. Is there a specific part of the statement that you feel like perhaps does that we might need to look at revising?
It's really in kind of the first part of the statement when you're defining. It seems like you really kind of narrowed it down by locking into that freestanding definition. So, can you find a better term? I don't really have anything other than, non-traditional hospital transport.
Our intention, or my intention, is only to take the recommendation forward, to have that published, because the rest of it can change. If everybody would look at the recommendation, if we just simply remove the word freestanding, would that give us what we need?
Well, I think that
Alternate care destination.
but I think the point of this really was to help us deal with the question of the freestandings. Perhaps we can deal with the issue by saying nothing in this position statement should be implied to limit the system's ability to transport to alternative designations.
Yeah.
Because it also doesn't really address transport to traditional hospitals, because that wasn't the intent of it. So maybe we just need a statement in there clarifying we're not trying to limit the options here. We're just trying to provide guidance on these particular things.
Destination is medical director supported. That's
Right.
already in the rule.
That's already in the rule, yeah.
We just need to clarify, if you want to have it just for freestanding, you clarify it. If you want to broaden it and talk about non-traditional or alternate destination,
Yeah, again, can y'all read it and see if I take the word freestanding out, what it does to the statement? Does it give us what we need?
I think the challenge is that the footnotes are still there. They'd have to come out as well.
Well, again, all that I would take forward is the recommendation. The position would be only the recommendation, only those 2 paragraphs you have there. And that's actually been my intention all along.
Chair, I think the concept is good, but I agree with the wording, more of a non-traditional hospital-based emergency department. And that would encompass,
Well, that doesn't do anything for mental health facilities.
well, it's non-traditional hospital-based emergency department.
They're not all hospital-based.
When you go
So-
to.
Yeah. All right, so I'm looking for guidance on this.
Yeah, I think the question is there a way to separate the alternative facility, alternative destinations while preserving kind of the content with, I think this adequately addresses true freestanding emergency centers, but our problem is the special hospital designation and satellite facilities which enter into this. So I think that's the scope of the area we're trying to address, and I think we're all in agreement the alternative destination piece is something we certainly want the flexibility for, and trying to separate those 2 out is a little bit more complex. So I don't know if we need to specifically exclude alternate destination facilities and how we can word that, or whether we just need to say it needs a little more work to get the wording down.
I guess my take on it is the intent really is to provide clarification on this type of thing, not alternative destinations. So perhaps we can just put a statement in at the end that says the scope of this does not encompass alternative destinations. It is specifically for freestandings.
So do we move forward with this position statement?
Yes.
And then next meeting, work on another position statement for other alternate care facilities?
But I agree that if we do move forward with this, we ought to have a line that says this does not address all alternative destination facilities.
I still think that
So it clarifies that part.
with the wording and the notation referencing the statute, the board rules, we're limiting this only to freestanding facilities.
I agree.
And I don't think that's what we intended to do.
Okay. So what do we want to do with it?
Make a motion that we go ahead and approve as written those 2 paragraphs, and then we come back next meeting start work on a position statement for other alternate destinations.
Okay.
Second.
Motion and a second. Discussion? All in favor?
Aye.
Anybody opposed?
Aye.
Is that an aye opposed or an aye in favor?
I oppose.
You're opposed?
He's winning like a
Nay.
Y'all lost. Y'all lost. Okay, so we'll move this one forward and bring another policy next time. Is that all right?
Yeah.
Okay. Who would like to do that?
Might as well, since I got
Doc-
the first one.
Okay. Dr. Bradley has volunteered to bring it forward next time. And just for clarification, we need to give Dr. Bradley some guidance.
Yes.
Do we want to make it incredibly vague about all alternate care facilities, or do we want to try to delineate mental health facilities, urgent care facilities? How specific do we want to try to make this?
We need
With a
to,
moving target.
we need to encompass alternative destinations. It's a push with the triple aim. It's a change going on right now. In fact, we'll be, some of us next week in DC talking about this fact that traditional reimbursement based upon transportation emergency department is going away. So we need a position that's forward-thinking about alternative destinations for appropriate patients.
And I would say, in particular, the ability for EMS to get paid transporting to alternative destinations.
And unless it's a violation of policies, I'd invite public comment to me also. Richard Bradley, find me on the internet. And I'll be welcoming any public comment as we draft this for next month, or next meeting.
Use a good spam filter when you Google Richard
Yeah.
Bradley. You
Yeah,
want
be
to
careful.
Be careful. Moderate on the images. Anybody from the audience want to say anything about what we're working on? Okay. All right. Number 5 was brought forward, I believe, by Dudley Waite at the last meeting. I don't see Dudley. I haven't heard Dudley, more importantly.
This was also discussed at the educational.
Okay. Cool. You want to take it?
No, but where'd the chair of the education committee go? Jody?
Jody?
Slacker.
Okay. So what, if you
So-
were at the Education Committee,
Lori, where?
Lori Lefevers is right here.
Oh, there you go.
Who's trying desperately to avoid eye contact?
Yeah.
He basically said that anybody can get a CE number now, and you don't have to have a medical director to do courses.
That's right.
And yet we've got transition courses that imply that it's an advanced process, more advanced. And so why not? If you have to have medical director for an advanced course,
Education.
why wouldn't you need it for the transition?
sir, we are discussing the request that was brought to us to discuss continuing education for EMS providers and the fact that there is no medical director required. Can you guide us?
Jody Herman, Tarrant County College. I think there was a loophole, and I think it's just been there. We had some outside influences, Leslie White and some others, we were talking and looked and thought, if you require a medical director for an initial training course, basic, advanced, provider level, you have to have a medical director. For continuing education, and I think it's just been a loophole that's just been there, but it's brought to our attention that someone could teach transition courses, the advanced level paramedic courses, without having a medical director. However, the same information could be taught through an initial course, you'd have to have a medical director. So when our committee looked at it, we thought, wow, it is just that. So the recommendation from the education committee, we'll be taking GTAC on Friday, is that we have medical director for all EMS courses. We didn't want to put CE or initial, just make it all so it's encompassing, because we believe that medical director oversight especially is important when teaching advanced techniques through an advanced level course through CE.
What if it's an online nurse course and you're granting medic CE hours? Do you have to have a medical director for the nurse?
I think that if we look at how nursing CE gets vetted,
Could learn a lot.
yeah. I think the vetting process for nursing CE is a little different than it is for EMS CE.
So I guess since you're taking this to GTAC,
Correct.
does the committee support this? Or
Yeah.
are we opposed, or do we have other comments?
I would certainly support that.
I think everybody on your committee was supportive, right?
What's the actual recommendation? Is it signature for CE approval or submission for?
We're going to leave the actual language up to dishes, but our recommendation is that all EMS education programs have a medical director.
I make a motion that we support what he just said.
Second that.
That includes CE programs.
Correct.
Okay, and I will do that tomorrow at the council, or Friday at the council. Anyone opposed to that? Cool, excellent. Thank you, sir. All right. There was also a request, I think, by Dr. Beeson to discuss advanced practice community paramedic programs.
I don't think I made the request.
You did.
Well, I obviously being intricately involved with this, it's been a big push nationally, multiple meetings. I think at this standpoint that is in our traditional fashion of this medical director committee and other medical directors in Texas is local decisions on these things. I am not a fan of a new recognition of some type of role or scope that doesn't exist currently, and there's no science to justify it. I'm concerned that there's a big push in certain states to create a community paramedicine / advanced practice paramedic without thoroughly thinking through that, and the concern for creating this limited box of a scope of practice. The current standing for most of the medical directors I work with that do these types of programs, that this is not expanded scope of practice. This is just an alternative role within our current scope of practice. And so at this point, there should be no support from us to go forward with some state recognition of some new delineation of paramedic.
So you're not opposed to community paramedics, you're opposed to a certification or such?
Yes.
Okay.
I absolutely agree, because I don't think they're all the same. I think they're very dependent on the needs of the community. I think the only potential benefit would be one, if you absolutely have to have it in order to get reimbursement. I think in the absence of that, and that would have to be exceedingly well defined, then there's no point in dealing with it at a state level.
Jeff, I work in Fort Worth and where you have that in place. And so how is that reporting done when they, advanced practice paramedic goes to check on those typicals, a CHF patient discharged 5 days ago, doesn't have Lasix because hospitals don't have outpatient visits? That comes through you, or that comes through their PCP, or that comes through the hospital nurses that go out and work with your paramedics, or how does that?
All the above.
Okay, so whatever works.
It's a community thing. Obviously, I'm the medical director of the program, but part of the involvement for our patients is a primary care physician involvement. And the big move and push right now nationally is mobile integrated healthcare. I think most of us will agree that we're not truly emergency medical services. We're unscheduled medical services. There are many pilot programs. There are a couple of federal innovations grants looking at these things. I think you will see in the future, Jeff, reimbursement will be for patient navigation to the appropriate destination, not particularly transportation to some destination. There's a lot of move going on nationally with this right now. I'm just fearful that everybody is trying to create some training program to train somebody to do something, yet we're not sure what that is yet. It's definitely a practice of medicine and must be guided by a physician.
So, no action on this, we just need to keep an eye on it?
No action.
Okay.
The action is to take no action.
So that way we're not being passive?
Correct.
Very good.
We're actively doing nothing.
All right. Any comments on this? Sometimes it's better to do nothing. I did not see Dr. Kidd. Is she here?
She's not.
She is not. And is there a report from the Joint Air Medical Ground EMS workshop? Or work group, not shop. Your group's not a shop, sorry.
Came together with the last GTAC, and I actually felt that this was pretty well addressed. And so I was visiting with Justin this morning. He feels we need to go ahead and submit the letter with the questions that Maxie's already answered with the term "do you agree?" And so we will be sending that to Maxie just to reemphasize what he said, and we'll do it before he
Leaves.
transitions.
Short timer. I guess so. Is there any action that this committee needs to take?
Not this time.
Okay. Any questions from the committee? Okay. And Maxie, you'll get that done before you leave, right? Huh? Okay. Whoa. For those in the audience that can't see the mean look. And then Dr. Morber, do you have a quick report for us? Okay. And then is Tony Gilchrist here? I didn't see him.
No, he's,
Oh, okay. Thank you. While we're pulling that up, I'll go on to number 10, the update on Texas Medical Board Rule 197. We discussed this at the last couple of meetings. The Texas Medical Board has completed and published changes to Rule 197, which is what governs EMS medical directors in Texas. They have changed the requirements to be a medical director to require a course, a DSHS-approved course. It's 2 years before or after becoming an EMS medical director, and then ongoing, or board certification in EMS, which is not available yet, although the first test will be in October. And moving forward, 2 hours of CME for EMS medical directors, as well as a requirement that, which we've asked for a long time, that physicians state on their renewal to the TMB if they're an EMS medical director. That's all education and registration. Probably the most confusing and somewhat controversial part of the rule change is there's a restriction on the number of EMS providers, meaning ambulance services, that a medical director can, that you can be a medical director for without getting a waiver from the state. I have not heard of anybody applying for a waiver yet, and I don't know how many people, wasn't the number 20?
20. And that
20
also is
services.
the same wording that goes along with the medical direction of mid-levels.
Right.
So that's where that came from.
Right. Yeah, so and that's not, there was confusion because people thought that meant number of paramedics or EMTs. Provider specifically means a transporting service, not a first responder. So the business actually for this committee and for DSHS is to approval of courses for EMS medical directors. And I'll look to the guy that's leaving as to how we can or what's the process that we would take to do that, or the state would take to do that. And do you need our help?
I'm not Jody Hobbert. Somebody else going to get that in a few minutes. We have an application. It's just like a course that you would apply for, and just fill out the paperwork and tell them that is the name of the course, when it's going to be taught, and what have you. Excuse me, these sinuses in Texas. I've been in Alabama, and they work real good, but I come back to Texas and they act up. But it's just an application process. I know Dr. Malone them had a course, and I don't know if it's been approved by us or whether they just taught it. Do y'all know if that course is approved by us? It's not. Okay. It's not approved by us, but I think that's a caveat. I think it says course approved by us or something else. There's another course that they would allow, if I'm not mistaken, in their rules.
MSP's course.
Well, we assumed NAMSP would be approved, but it's,
Okay.
that's not in the rule, I don't think.
I think there's something else in the rule. I don't know off the top of my head. I didn't look at it this morning, but yeah, it's a simple process. They just like
Really?
CE. It's just like CE. You send it to us and tell us what you're gonna do, and we just approve it.
No, it's,
So who approves that? I guess
It's our compliance people, Brett Hartnum shop over there.
Okay.
They just send it to them.
Should we offer our assistance? Uh-oh.
Sure.
I mean, we help to push this. It seems like we ought to
Well, I
offer.
think that there should be some minimum standard for this course. You know, not just necessarily, I'm taking a course in medical direction.
Yeah, I would think if we want a medical director to oversee the CE for paramedics, it seems like a medical director ought to be involved in a course for medical directors.
We'd like for you to design it, then. Just design and tell us what you want in there, and if they meet your standards, we'll approve it.
Okay.
And it needs to be specific to Texas.
Yeah.
The rules in Texas.
So it sounds like we have work for this committee?
It sounds like it, yeah. We appreciate any help.
All right. And who would like to take run with this one?
I think he said Dr. Malone already has a class, so she nominates
Well, good.
herself.
Is there a second?
Yeah,
No.
Second. Aye.
Oh, Dr. Malone says she would be honored, which is not, I think, what her first thought
Dr.
was.
Jarvis is going to help me.
Yes, he will.
All right. Thank you, Maxie. Yes, sir.
So I sent out this Texas.
Who-
I'm Aaron Buzzard, by
There
the
you
way, the Brazos Valley Regional EMS Medical Director. I have multiple services. I sent the Texas Medical Board rule changes that were adopted recently to all my paramedic directors for each service. And I asked them to go through line by line to make sure that we were in compliance with that. And those two issues that you just were discussing came up with each director. And they asked me to clarify about the 20 EMS providers, if you could maybe go into that in just a little more detail, and I'll tell them what your
Yeah.
answer was. And then the National Association of EMS Physicians Medical Director course was brought up because myself and some of the associate EMS directors have taken that course. And we wanted to know how to get the steps done now so we can get approval for what we're doing already.
Those are two good questions. And I forgot to mention, I've had some communication with Mary Robinson with Texas Medical Board. They are going to post on their website some FAQs about this to give us some direction. I forwarded to the Texas Medical Board questions that were sent to me, just like those. Again, a provider under the rule, and as it is defined, is a transporting EMS agency. So Houston Fire Department is one provider. They have lots of first responders, lots of ambulances, lots of paramedics, but they are one provider. I don't know how many people are out there that have 20 different services. I don't think there's a lot. And then your other question was about the NAMSP course. The way you take it is to sign up for it. My concern with the rule coming out is I took that course about 20 years ago. And the rule says 2 years before, 2 years after, so I guess I'm going to have to take it or another course.
Well, do you want me to read the actual rule? I've got it
Sure.
pulled up here. It says, within 2 years, either before or after initial notification to the board of holding the position of offline medical director, 1 12-hour of formal continuing medical education is defined under 166.2 of this title in the area of EMS medical direction. That should be the NAEMSP course or another similar course. 2, board certification in EMS by the American Board of Medical Specialties, or a certificate of added qualification in EMS by the American Osteopathic Association. Or number 3, a DSHS approved EMS medical director course, and every 2 years after meeting the requirement, 1 hour of formal CME in the area of EMS medical direction.
And I believe your question was, you've taken the course and you're wondering how to get recognition, how to essentially prove that you've taken it?
There's actually, when you read the rule like you just did, it gives you multiple pathways to meet the standards for that. If I interpret the first one, where it says 12 hours of formal continuing medical education as defined, that's separate from the actual medical director's course, which is item number 3. So if you take the medical
No, it's one of those 3.
No.
One of 3, not all 3.
So if you take the medical director's course, then you're good.
Good.
Yes.
Yes, sir.
But if you have an older course such as you mentioned you have, then if you go to the national meeting every year, which generally is more than 12 hours of CME that's specific to EMS medical direction, that should also.
But that's not a formal course in EMS medical direction. So that qualifies for your CME. That qualifies for your 1 hour of CME every 2 years. But the NAEMSP course will qualify for number 1, the 12 hours of formal CME.
So those who are outside of that 2-year window are going to have to find another course and then submit it, is that correct?
Yes.
Well, I guess
Yes. Yes.
DSHS is not going to be the one that will be getting these submissions.
No, it's Texas Medical
Yeah.
Board, yeah.
And I'm not sure, I think that's probably going to be like our CME. We're not required to turn that in. It's a
Right.
matter of if you're ever audited, you have to be able to prove that you did that.
And it may be under the FAQs, and if we ask Texas Medical Board, what if you took the course 15 years ago? Would there be like a grandfathering in? Because I think most of us took it a long time ago. So again, that'll be under the FAQs.
It's painful to take again.
Yeah. it would
I don't know
be-
that
it would-
there's anybody up here who's taken it within the last 2 years.
I did. I actually took it again last year.
Gunner? Okay.
Yeah.
All right. Did we answer all your questions? And we certainly aren't the Texas Medical Board, so you can't trust anything we said.
We never do.
Thanks.
Can this committee basically put together lists of what they would recommend
I-
to fit those criteria?
That's what Dr. Malone is going to
Yeah,
work
that's
on.
what we're going to ask Dr. Malone to do. Not, I guess we should clarify that, what a course should have in it, and then hopefully we will identify some courses we think that meet those requirements.
Minimum content.
Primarily content, minimum content.
Yes,
There's several that have that. I mean, AMPA has
right. There's a,
all those things that count as well.
I think so. Okay. Anything else on that topic? Dr. Morber, you are up if your technology is working.
I'm just presenting today a small, can you hear me?
I can.
I'm presenting today a small snippet of what our committee has done. As you know, in the 1960s, John Kennedy said, "We're going to the moon." It's not because it was easy, it's because it was difficult. This is probably one of the most difficult aspects that we have to deal with in catastrophes. We have to go to crisis standards, and we have lack of resources. In so doing, we have also advocated that we have coalitions between our jurisdictional incident management and our healthcare coalitions such that they can work in uniformity and they work regionally. Because what we're advocating is for guidelines from this committee that needs to be translated down into the tactical responses that the communities will consider. So the World Health Organization states that the class 4, phase 4 is human-to-human transmission, and this is where we're talking about in a pandemic. Prior to that, it's up to surveillance and situational awareness. Excellent. So what we're trying to do is pandemic influenza by using a targeted layer containment strategy, which is the term used by the Institute of Medicine for early detection, treatment with antiviral medications, use of infectious control measures, including isolation and quarantine, dismissal, and social distancing measures prior to the onset of development of the vaccine. And what we want to do is move this bell-shaped curve, which would occur in any catastrophic event, as far to the right as we can to limit the effect of the response that is going on. Next slide. So what we're trying to do now is develop a timeline. What we have, and we're thankful what Utah did, but Utah is a state of 2.8 million people, 52 hospitals, and 2 major trauma centers. We have 26 million people, 554 hospitals, and we have probably half of the hospitals are registered as designated in some form of trauma. What we are looking at is a timeline to develop what they call conventional standards, which is everyday operation, to contingency standards, what if something happens, to crisis standards when all hell breaks loose. So what we're looking at syndromic surveillance and situational awareness are our public health and epidemiology colleagues to let us know when this process will begin. And when we're looking at pandemic, we're looking at level 1, 2, and 3. Level 1 is a surging event when we recognize that something's going on. Level 2 is we're already at capacity. We can still function, but we're at capacity and very limited. And level 3 is the oh my God context. So what we're trying to do is take the conventional standards and correlate that with the levels of triage we have. Conventional, contingency, and contingency standards would begin when we begin the surge. And these would ramp up as it gets to level 2, which is at capacity, and just before we end up with crisis standards, which someplace would be within the level 2 area. And what we're talking about is hospitals, and we've dissected already the situation that Florida's put out. It's very concise. It doesn't fit the standards for the state of Texas, but we've dissected that down to accommodate our state. Additionally, I would like to invite anybody on this committee. My next meeting is the 22nd of March, and we're going to dissect the EMS role in the pandemic. We have to discuss what's going on as business as usual with the 911 systems, how the calls are coming in, when we transfer to a 311 system, when we tell people to take care of themselves at home, go to the PCP. Do we transport? Do we not transport? Do we have alternative transports, as Dr. Beeson had talked about? And when does this fall into line? When does the changes in dispatch occur? When do we stop coming at level 2 when we're already surging and we already know we're at almost maximum capacity? We have to make a decision if we're coming, if we're not coming. Even though we'll be taking care of strokes, heart attacks, but for flu-like illnesses, there's going to be a big question, what do we do? And then the oh my God complex, we're not going to get all. This also filters down, next slide, into other areas when we talk about communications. We have to have standard communications and then develop what we call multimodal communication, which will begin with when we first recognize that something may occur, and then onwards into the surge and at capacity, so that we can have different messages go out at different times. These have to be both proprietary and public. We have to teach the public what to do during the situation, and we have to be able to communicate among ourselves and also be aware of what's going on in social media. So we have the effective judgment of what's going on in social media. We also have to develop what we call medical understanding of sustainable treatment, because we're talking about classifications of people that will be denied access. And we have to be very cognizant of the fact that we have to have an informed consent when we are going to have deny people access to the usual methods that we do today. So if they're fall into certain criteria, they'll be allowed certain sustainable methods of care, including palliative care, but they may not be allowed to have all the care that they would have had, including ventilator support. Then we also have to consider force protection, and we're discussing what to do with force protection, which has to begin early on for a public and private sector, and then into the hospitals regarding use of antivirals, which is the recommendation is limited to a new novel virus, and then on to vaccination when that becomes available. And then there'll be other parameters that we'll talk about. So the next meeting is the 22nd, and I'd like to invite anybody that would like to come and we'll hash out what the next steps are.
Where is that meeting?
It'll be at the Bishop Spot from 9 to 4.
Any questions for Dr. Morber? Thank you, sir. All right. Board. Sorry, I've got too many pieces of paper here.
Thank you. Now you can hear me, so I'll just repeat that in case you didn't hear. My name is Manish Shah. I'm the program director for the EMS for Children State Partnership in Texas. I'm here on behalf of the state partnership since Tony Gilchrist, our program manager, has accepted a new position as the EMS program manager for the EMSC National Resource Center in Washington, D.C. We're sad to see him go, and we're in the process of finding a new program manager, which you'll meet at the next meeting in May. But I am here to discuss a pediatric protocol resource tool that we have created in response to feedback. Initially, 4 years ago, when we took over for the state partnership in Texas, one of our questions to you as stakeholders in the state is how can we help you as pediatric content matter experts? And one of the pieces of feedback we received was guidance on creation of pediatric relevant pre-hospital guidelines, or how to incorporate the needs of children into existing guidelines. And so one way that we have chosen to respond to that is our evidence-based summary project that we did last year, and now we're almost ready to release a website on our EMSC website, a web portal that we're calling the Pediatric Protocol Resource Tool. This tool is intended to do three things. One, it's intended to share with you pediatric evidence-based guidelines for care that exist. And so one of them that we have created as part of EMSC grant funding that we've received is a pediatric respiratory distress protocol. We've implemented this in the Houston Fire Department EMS system, the City of Austin Travis County EMS, and BioTel EMS in Dallas. We're currently studying it to assess outcomes, but we are going to release it on our new website in the next month. In addition, we have created evidence summaries, which Tony had sent to you, Dr. Greenberg, and I believe you had distributed to the rest of your committee. We have created evidence summaries in situations when there is not enough guidance from the literature to create a full guideline or protocol, but there is existing literature when we can potentially address some controversial issues. So we focused on cervical spine immobilization for children, post-resuscitative care for children, issues related to non-transport, and the last one was management of non-traumatic shock. So what we've done is we've addressed what we feel are 3 to 4 relevant questions for each of those topics based on stakeholder feedback we received at prior GTAC meetings, and we have provided evidence summaries for each of those. These are summaries that we intend to post on our website as soon as the website goes live in the next few weeks. And then the final part of this web portal will be access to resources for creation of other guidelines based on existing guidelines that are present. So for example, as part of a national work group with NHTSA and the EMSC program to create a pediatric seizure guideline, there's also ongoing work with EMSC and NHTSA to create a pain management guideline and a helicopter EMS guideline. All three of those guidelines are supposed to be published in an issue of pre-hospital emergency care in September, so they're undergoing review. And so as soon as those are published, we would reference those as resources on this web portal. So one of my reasons for coming today is to seek the GTAC Medical Directors Committee endorsement of this as a resource to be used by other medical directors in Texas to provide guidance to integrate the needs of children in the pre-hospital protocols that you use. They're not intended to be adopted as is. They're meant to be viewed so that you can look at the evidence and decide based on what your resources are, the scope of practice of your providers, your practice setting, and those sorts of issues, availability of online medical direction, how you would adopt this into your own practice for your agency. So they're meant to be customized for the needs of your agency and your location.
Right. And you're not asking for specific endorsement of the individual. You don't want us to go line by line through the guidelines.
No, we're asking for endorsement of this as a resource as a whole to be made available for use by medical directors in the state to seek guidance when creating guidelines that incorporate the needs of children.
Okay, and we have links on the medical director committee website page So we could just simply put that as a link. Would that be what you're looking for?
Yeah, that would be
Okay.
great.
How does everyone feel about that?
Yeah, I'd like to make a motion along those directions that GTAC Medical Directors Committee endorse the pre-hospital resource tool as a tool to help medical directors make protocol changes as necessary.
Got a second? Motion and a second? Any further discussion? All approved?
Aye.
Yeah, did I go too fast? You want to say something?
Well, my only thought is we haven't seen it yet, so I'd kind of like to,
Well,
the actual guidelines.
they're there.
They're available.
They're there.
Oh, I didn't think
Yeah, they've been up.
Yeah, we've emailed it to Dr. Greenberg for distribution to your committee for review. I know that Dr. Spear
I
has
took a look
reviewed
at
it.
They're very helpful. I mean, they're evidence-based. A lot of places there is no evidence. The one I find most helpful is the C-spine issue, that if a medical director, wherever their location is, wants to implement a C-spine clearing in pediatrics, it's a real concise evidence summary, and they would be able to say, at least, I'm doing this based on these recommendations.
Yeah, and we're not saying this is the protocol, use it. We're saying use this protocol to develop your own.
Correct. Yeah, this is your endorsement of this as a resource that you could go to provide helpful guidance when integrating the needs of children in your protocols.
Okay. All right. So does that change anything for us?
No,
Okay, just want to make sure. I think I zipped too fast for you.
I believe Dave.
Okay. Thank you, sir. Is there anything else?
Just one question for you. In addition to those guidelines, are you willing, and have the subject matter experts willing to review medical directors' protocols prior to their publication?
So that is something that we have been asked to do in the past. From a resource point of view, that is difficult for us to do. So what we're hoping to do is that we're hoping to address the most the guidelines or protocols that will potentially have the biggest impact on children, in the sense that they are either the most common things that you see, or they potentially are critical situations when you need guidance. And so what we would do is we welcome your feedback in suggesting what topics we should address next, so that if we put out evidence summaries, we can address those based on the feedback we get from you. The reason why is to do a full, even just to do an evidence summary, it took some additional funding and 3 months of work from other people besides myself. And so to make each one is quite time intensive. And so, so it's hard for us to review each person's protocols.
Yeah.
Yeah.
All right. Thank you, sir.
Sure. Thank you.
So I'm going to jump ahead a little bit, and that concludes actually all of the agenda items prior to public comment and announcements. I have going forward to the council on Friday our support of the educational position statement we previously have done, our support of the freestanding emergency department position statement, with a caveat that we will work on another one about alternate destinations in an attempt to make some people happy. Will that do it? And I think those probably should be separate as the more I think about it. I'm going to put forward Dr. Beeson's name for the work group. I'll let them know that we have agreed to help with the EMS medical director approved courses through DSHS, and that we support the education committee's position on physicians for CE programs. Is there anything else the committee feels I should share with the council?
Dr. Malone being in charge of
course.
And getting input from all of the
Dr.
knowledge in the
Jarvis.
room and at the table. The real Dr. Jarvis or you?
Yes, one of
The substitute.
Jeff will help you with that. So, agenda items for next meeting. Anything we have discussed today, or anything that someone would like to bring forward?
Non-traditional transport destination.
Okay, yeah, the non-traditional transport destinations. Dr. Jarvis, it seems like you had something, and I can't remember what it was.
Be done by May.
The issue that I talked to you about, Maxie actually resolved for me, but just to let you know, wow, these are sensitive today. One of the things that I find myself doing is revising my protocols seemingly on a daily basis now to account for the drug shortages. And every time I do that, I have 16 trucks in service, so I have to get 16 copies of a coordinated document and keep those up to date across the system, and it's getting to be quite a problem. The question I had for Maxie was whether we have to do that in paper or whether we can use an electronic version of it. And he explained as long as that electronic version is always accessible when the vehicle is in service, then we can use an electronic version. So I know for us, I have a commander who's used to actually have a name. His name is now Commander Paperwork, who is greatly relieved to hear we can use an electronic version of it. So thank you, Maxie.
Any other issues for the next meeting?
No, I just, a lot of the legislative bills, I would challenge everybody, it may be too late by that time, but to look at what's out there and let your voice be known.
Okay. All right. Our next meeting dates,
Speaking of that, one of the legislative things was the state medical director.
microphone. Sorry, sir.
State medical director was one of the things that got mentioned. I had not heard of that. Who's bringing that up and why?
Well, it's actually my rep that brought that forward.
And you let him?
Do what?
You let him?
Well,
Guess who it would affect?
what it in, and first off, the bill is very short. It basically says that whoever is the EMS medical director on GTAC is the state EMS medical director. And at the same time, I also very quickly said, and if that passes, I will resign effective then, because I don't want to be seen as creating a position for myself. In discussing this with him, a few things came up.
That's a pretty creative way to get off a committee, you know?
Yeah. See? I'm thinking. First off, a few things. First off, I don't think that this position is anything that the people in this room necessarily will benefit from. The people that will benefit from having somebody in a position such as that, where they would have strictly a liaison type role, and that was what I told him, was this person does not need to have any authority other than to be able to liaison, especially with the rural EMS medical directors. The people that are in this room generally are not the ones that need somebody to help them out with some of these things. It's those medical directors that we can't get a hold of because we don't know who they are, for one thing, and because currently there's not really any impetus to have any interactions with those people. And so that particular role would strictly be to liaison with those, especially rural medical directors. Additionally, representative, because currently I am recognized as the state medical director by NASIMSO, but we don't actually have that position. There's no funding or any mechanism to assist with that. And, there are some federal things that are coming down the pike that actually we don't want, and particularly in the form of the federal EMS agency that is being put together, because what do those things tend to end up having? They end up having national guidelines and rules. And so, I know that there's been heartburn, and several people have said, well, we can't have that because we don't want state protocols. Absolutely, I agree. And that's why this person would strictly be a liaison and representative type role and would not have power to do something such as that. But also because we need to make our voice known as much as possible in the federal system to avoid having that same thing shoved down our throats. So, yes, it did come from my representative. I've discussed it with him, and I'm not sure exactly how it came to him, but, at the same time, those were my recommendations to him. And no, I will not take that job.
So I'll just jump in. I think the value of that position, although we've discussed this before, is controversial. I think there's no question in my mind that for liaison, information flow, recognition of the things that we're doing at the state level, I think it's really a needed position, we need to define what that role is and how it can be best utilized to our services and allay fears of all stakeholders involved. But truly, in my mind, there's no question that we should have physician leader representative available and coordinating some of those activities and reporting back to medical directors in the state. You're absolutely right. There's much that's being done at the national and federal levels that we should have folks at the tables for.
Do we have a number on the bill?
It's 409, House bill.
Do you know, has it been scheduled for hearing? Do you know?
I don't know that it's been scheduled for hearing or anything, and I looked it up while ago, and it's gone to Homeland Security Subcommittee, committee. I'm not sure exactly why there, but that was what it showed.
Wow, okay.
Yeah. And there's a couple of other bills that are of interest to EMS medical directors that we should be aware of if we have time to discuss it. I think it's entirely up to you, Mr. Chair.
Let me say first off, our next meeting date is May 15th and 16th. I will beg the state to not put us the afternoon of the 16th because I have to be in San Antonio for a TMA meeting that day. So we can, hopefully it'll be the 15th or the morning of the 16th.
It's here.
Yes, it will be here again, same hotel. And then GTAC itself will be on the 17th. Let me take a few minutes first. There was something I was asked to do by the chair of the council, by Chief Riley. There was a conference call a week or so ago discussing again shortening our meeting time to 2 days. A lot of different issues around that. The chairs, the executive committee of the council who was on the conference call, that's the chairs of all the committees and the chair and vice chair of the council. I was asked to ask this committee, basically, do you feel like we could get our work done in an hour and a half that we have, or even sometimes in a shorter amount of time? And any general thoughts about a shortening of the overall GTAC meeting times and committees to 2 days?
In favor of it.
I think particularly if we minimize the overviews of what other committees are doing, I think we might be able to get more.
Yeah, and let me clarify that some too. The attempt will be to take some of the reports, like Dr. Morber's report, who I think he gives that to multiple committees, Dr. Kidd, DSHS reports, all of those would go to a council meeting that starts however long the sessions are, and we would then have the council hear those reports, and anybody else that wanted to attend hear those reports, and those would not then be repeated at each committee. So, is there support, problems, concerns?
I think it's a great idea.
Excellent idea, cost saving.
Okay. All right.
496.
What's that? That's
496.
So it's in committee?
House Bill 409 is in committee.
Okay, 409 has been sent to Homeland Security and Public Safety Committee on February the 11th. That unfortunately doesn't mean it goes anywhere from there. We know they can sit in committee. Any other comments from the council, from the committee? And then I'll let Dr. Manifold discuss some legislative issues, or inform us we actually cannot discuss or take any position on. So, floor is yours.
I'm certainly not an expert, but I think there's a few things that are of interest to EMS medical directors. One, addition to a bill that's asking for EMS medical director vehicles to be identified as a emergency response vehicle. That's not clearly identified in statute at this point in time. There's another one that, and I'm sorry I don't have the numbers, I wasn't prepared for that. Another one that's introducing telemedicine, which includes in their language something along the lines of having established a patient-physician relationship, much like in an office. And some of the concerns in the request through TTAF was to request a EMS exemption to that, because it's not necessarily identified as telemedicine in the traditional role, but even potentially communication such as EKG transmission, interaction with some of the video and audio capabilities could be misconstrued in that. So, and then I think there's a bill that you're very familiar with, Bobby, on the emergency detention, where the EMS component of that, is my understanding, has been removed or is going to be removed from the language, but it will address only emergency physicians being able to perform emergency detention.
Right. House Bill 245 from Menendez, who is in San Antonio, is to allow physicians to hold someone who is mentally ill without having to get a police officer or a judge. There was an EMS piece to that bill initially that, quite frankly, I think was a surprise to a lot of us. I'll have to say I think it's a good idea, but it came as a surprise, and I don't think it can get the support it needs. So the authors are going to remove that from the bill. There will be a modified bill coming up.
One physician can do it, or would you?
It's currently written one physician,
So we can still do it.
and it'll be an interesting discussion at the Capitol, and I will be there for that discussion.
So one of the discussions would be whether EMS medical directors can perform that in the field.
Well, correct. And more interestingly is, can you delegate that authority?
Yeah.
So it'll be, so we have time left, somewhat to my surprise.
I know there's a bill, Chair, on something to do with legal blood draws. You know, it's been one of the controversies for years. Yes, EMS, no EMS. Now it's back, yes, EMS. There's also one that will affect some of the rural providers about carrying guns on ambulances in rural areas, under populated areas. So that's another thing that may affect medical directors.
Okay.
That was intended for a purpose. No, there's a bill about, I don't know the exact wording, something about legal blood draws again, about something about making providers draw, a legal blood sample. Oh, I got a hand raised back there. And there was also a bill I know I just was notified about that is wording allowing EMS practitioners to carry weapons in underserved as he grabbed his gun, in unpopulated areas, which thank God does not Fort Worth. No? Grab the one to your left.
No, no. Talk loud.
All right, the blood draw bill is riddled, and it's the same bill that it's the third legislation that we tried to put this through. It does not require, it allows.
Okay.
So it's up to the medical director to determine whether or not they want to allow their EMS provider to draw the blood. There's language in there that's very specific about it can't take the place of patient care or get in the way of patient care. And it's strictly, it's up to the medical director for that service to allow it. There is another bill by Sylvester Turner that's completely opposite of that denies a police officer the ability to gather the blood at the scene from either the officer himself drawing the blood or tasking somebody else to draw the blood. So, like I said, this is the third time. This bill was written by Riddle. We had a group, myself, Dudley, and the police officers and some prosecutors sat in a room and came up with some wording that we felt very comfortable with, especially since it allowed each individual service to make that decision for themselves. It does not require.
Okay. Was the intent of that to provide protection for someone who is willing to do that?
Yes. And also to allow that there are some rural areas where if they have a suspected DWI, they have to drive hours or sometimes longer to a hospital to draw the blood and to be able to get the blood at the scene.
Okay, thank you. Any other comments? Any public comment? Really? Dr. Kovar, come forward, please, sir.
He said public.
So there's an opportunity with this kind of organization, you hate to add layers and layers here. You hate to keep adding layers and layers, to the organization, but when you realize the networking and how things have moved forward with this organization and the subsets and, trauma has branched out to cardiac care and stroke care, et cetera. Some of the issues that are up, I'd like to have this committee consider, supporting expansion for our mental health issues, because they have a huge impact on, our EMS runs and our emergency practices as well. There's a lot of,
inequities in the managing those patients. They cause significant delays in the delivery of health care to everyone. There's a significant component of trauma to the majority of those mental health calls. It's not terribly supported as far as within this organization. It's not well funded, and perhaps rolling that into this type of setup where you do have pretty well funded programs such as stroke and cardiac and even trauma. Maybe those guys can find some solutions and some connections in considering another division to talk about EMS and mental health and emergency department issues.
What do you mean? What do you mean by another division? You talking about for
Well,
this
we
committee?
we have a pediatric committee, we've got a stroke
Okay.
committee, we've got a cardiac committee, and we have absolutely ignored mental health issues. And I think it's a huge gap, and this is the appropriate place for it. That's just public comment.
All right. And we will. I just put mental health issues for EMS medical directors down as an agenda item for the next meeting.
Please clarify, the medical directors do not have mental health issues.
I think we need to discuss
I don't
that.
believe he can say that.
Mr. Chairman, I do want to recognize the fact that we have all but one of our members here, and I think that's phenomenal compared to a lot of committees.
Yes. Yes, great. Excellent. Any further business?
Thank you,
We
Maxie.
are adjourned.
Maxie's
Oh,
last
yes.
Oh, yeah, thank you, Max.
Yes, I forgot. Maxie, we do appreciate everything you've done. And we know you're not really leaving us, right? Can you actually announce to everybody who doesn't know what you're going to be doing? Yeah, you need the microphone.
I'm going over to TDEM to work for under Cmte. He pulled me over that way, so I'm going to the other side of the state. Right down the road, actually, in the SOC. So kind of excited about it. I'll be the EMS training coordinator for TDEM.
Okay. All right. Well, thank you for everything you've done. We appreciate it. And we are adjourned on time.
Good job, Chairman. Amazing. Well done.